इसमें से वो उसका जो ये है ना वो नहीं चल रहा, उसका जो कनेक्शन है उसमें मैच नहीं चल रहा। Morning. तुम्हारे पास तो एक मैं लिख के
कहाँ नेक्स्ट कनेक्ट व्हाट्सएप पे मैडम व्हाट्सएप पे था कि ना व्हाट्सएप से छोड़ दो इफ यू यहाँ से क्या दीदी इफ यू हैव इन द व्हाट्सएप ना गिव इट इन द व्हाट्सएप yesterday I did have WhatsApp
The net is very poor here. Net बहुत poor है.
Okay, good morning again. Sorry for slight delay due to some technical issues. On behalf of APNEICON organizing committee, I welcome you all again to the Patna in Patna. Such a beautiful morning, sunny and warm. So, कल देखा आप लोगों ने कल के अगर क्रिकेट के शब्दों में कहें तो कल के ओपनिंग बैट्समैन गोपाल सर काफी बढ़िया स्टार्ट हुआ. Difference between adult PKD, pediatric PKD, and then we go on to the dialysis, then transplant, and then such a surprising talk by Dr. Raja about all the biomarkers in the kidney. So after such a wonderful first day, we are going to start with the second day of scientific session. And today we have the first session we are going to start with. That's a spectrum of general pediatric dialysis about the caput And for moderating that, I will request Dr. Jayanti Sengupta ma'am. So please come on the dais. And for the panelists, we have 4 people: Dr. Rana Saha ma'am, Dr. Streming ma'am, Dr. Salini ma'am, and Dr. Vijay Lakshmi Jaina ma'am. Sorry, sir. In the galaxy of so many stars, I mistakenly said, sir, but I'm applied for the that thing, sir. So over to you, ma'am, Dr. Jayanti Sengupta.
Thank you, and I'm so happy that Sylvia is getting the opportunity to be the first on the dais in this lovely APNEICON conference being held in Patna. Yesterday's, as you said, the first day was a good show, so let's hope we can, pre-lunch, we have a very good session and we can keep you awake. Okay, so now we start with CACUT, and I welcome all my panelists here, Dr. Rana, Dr. Streming, Dr. Shalini, and Dr. Vijay Lakshmi, each coming from different states of Eastern India, from West Bengal, from Bihar, from Jharkhand, and from Orissa. Okay, so why is CACUT important? Now, CACUT is the congenital anomalies of kidney and urinary tract, we all know. The kidneys are developing from around the 3rd week of embryogenesis, and they continue till around 36 weeks. So it's a huge time lapse between which the kidney and the urinary tract develops. And so as a result, because of this huge time that it is happening, it is under a lot of threat from a lot of environmental as well as genetic issues and insults, which makes it its development very, very susceptible. And so we often have a lot of anomalies happening because of this long period in which the embryogenesis takes place. So we see that CACUT is the most common of all birth defects. And in children, it accounts for around 35% to 40% of cases of end-stage renal disease, for which renal replacement therapy and transplant is required. So that's why knowing about CACUT is so important, so that we can diagnose them early, we can initiate treatment early, and so as to prevent further damage to the kidneys. Okay, so as we just said, that since the embryogenesis is for a long time, there are a lot of different types of presentations that renal anomalies can present with, children with renal anomalies can present with. So my question to Dr. Streming, can you just enumerate the various common clinical presentations of CACUT?
So, very good morning to all of you. In terms of CACUT presentation, the presentation starts from the antenatal period and progresses as the child grows. So, in the antenatal period, one of the most common things that gets picked up in an anomaly scan is hydronephrosis, where there is a dilatation of the anterior ports in the pelvis, and then there are additional anomalies which can be seen in terms of the abnormality of the kidney echogenicity, kidney number, that is agenesis, dysplastic kidneys, and there could be an associated complication resulting from that, that could be oligohydramnios, and there can be additional anomalies in the ureters and the bladder. So that is the antenatal part, and then the child develops. The usual presentation in the neonatal period could be an abdominal mass. There could be obstructive pathologies behind it, so there could be difficulty in urination in the urinary stream, and there could be abnormalities resulting from that complication. Could be UTIs, and there could be an anomalous origin leading to ectopic forms which can lead to enuresis. So these are the common presentations, and as the child grows, sometimes they basically present to us in end-stage renal disease at times or in the advanced stages of CKD.
Yes, so there could be different presentations antenatally and postnatally depending on where we pick up the child and when we diagnose them. Okay, so as we see that the time frame for CACUT defects is very long. So patients who, so in children or in embryos, where the defects start very early, say around 4 to 6 weeks, when the ureteric bud induction is happening, we get mainly patients who have agenesis of the kidney, we have renal hypoplasia, we have severe dysplastic kidneys. When the embryogenesis is a little longer, so if the insult happens between 6 to 10 weeks, when the uretary bud is branching, then we have problems like duplex kidneys, we have ectopic ureters, we have obstructive ureters. And if the thread is even longer, when it is even later, like in late gestation, when the parenchyma of the kidney is forming, then we have what we call cystic dysplasias, we have echogenic kidneys. And last but not the least, we have a lot of environmental teratogens, genetic mutations and epigenetic influences, especially the maternal environment, maternal drugs, which can all lead to the pathogenesis of catgut. Okay, so in a very small nutshell, we can say that the catguts can present with either abnormalities in anatomy, like in number, in sizes, in position, or it can present with anomalies in physiology. So there may be dilatation, there may be obstruction, there may be dysplasia, and they may present just as a single anomaly, or they may be present as part of many anomalies or any syndrome. So as we go, we will see how the different types of presentations affect us and how we can diagnose them. Okay, Dr. Rana, how do you approach a case of suspected catgut at birth, from the history, presenting symptoms, investigations, etc.?
So some catgut can be diagnosed by antenatal scan, while some other catguts are present till late childhood. So while taking history, we have to concentrate on whether this child has got any history of UTI, and is there any increased frequency of urine, any bedwetting. And so also we have to look for urinary stream. Poor urinary stream is also suggestive, maybe some obstructive lesion. And also general growth and nutrition of the child, and other general symptoms like chronic abdominal pain, and any family history, any siblings already involved with catgut. So those are the things we have to consider in any child suspected to have congenital anomaly of kidney and urinary tract. During examination, we have to again concentrate on the growth of the child, any abdominal mass, or any other extrarenal features. Like catgut, we know, can present with other system involvement, so we have to look for those also. While investigating, it depends on the type of the catgut and also the severity of the catgut. We have to assess the renal function, we have to look for the GFR. At the same time, we have to do the scan. So again, depending on the severity, the scan can be delayed within the first 7 days of life, or if you are suspecting a lower urinary tract obstruction, has to be done within 48 hours. And subsequent follow-up depending on the types of involvement. If there is any obstructive lesion suspected or any upper tract dilatation, we have to do a MCUG, micturating cystorectogram, and if that suggests a reflux, or it doesn't suggest reflux, then we have to go for DTPA scan or DC scan to confirm that there is no upper tract obstruction. So, summing up of that, catgut children who present with can be associated with external features, so we have to complete our physical examination looking for the other system also.
Good, yeah, so I think that's about it. Now let's get to some cases. Case 1. So we have a child, fetus in the second trimester having a USG showing an APD, that is an anterior posterior diameter of the left kidney, left fetus, 7 millimeter. And in the third trimester, the anterior posterior diameter increases to 10 millimeter. The obstetrician is referring this child, this fetus rather, to the pediatric nephrologist for counseling and future prognosis. Now my question to Shalini. You've seen the antenatal scan. How do you interpret an antenatal USG? And what do you think are the factors which are most important in the course of management of this child?
Yes, thank you very much. And to interpret an antenatal USG, we have to screen the patient at the anomaly scan or the anatomy scan, and the features related to the renal anatomy and anomaly. We need to see the renal pelvic diameter, and accordingly we grade the severity. If it is less than 4 millimeter in the second trimester, it is mild, and it is severe when it is more than 10 mm. However, in third trimester, the normal is less than 7 and more than 15 mm is the severe. Then amniotic fluid index, it is principally maintained by the fetal urine, which production, majority of it is accounted for by the fetal urine by 16th week of gestation. And so we have two parameters. One is amniotic fluid index and the single digit pocket. So polyhydramnios is defined as more than or equal to 25 centimeter in AFI and more than 8 centimeter in the STP. Having said that, STP is more reliable for oligohydramnios and it is borderline when it is less than 2 centimeters. And other factors which we need to see is the fetal growth, bladder length, and the profession of the renal pelvic diameter. If it is more than 4 mm per month, then how the fetal bladder length is increasing, and the hydronephrosis and the elongated renal length. So, the factors which are more important in the hydronephrosis management are: one is Society of Fetal Urological Grading, when grade 1 is sinus open, when there is just a spreading by urine, and the grade 4 is parenchyma thick. But UTD risk stratification, that is urinary tract dilatation, it takes into account, in addition to the renal pelvic diameter, whether there is central or no canalicular dilatation, the parenchymal thickness, ureterus, bladder, and unexplained oligohydramnios. So it is a more comprehensive stratification. The other factors which we need to see are whether there are cardiovascular, neurological or gas system anomalies or the skeletal systems, and the soft signs are increased nugget translucency, acid finger bones, echogenic bowel, and echogenic focusing heart, clot in long bones, chloride fractures, cysts or ventricular mechanism.
Yeah, so I think if we can just sum up, the in antenatal scan, first you see whether it's a bilateral problem or a unilateral problem. The moment it's bilateral, you have to act fast. The next most important thing is the epidiameter. Anything more than 7 is important, is hydronephrosis. Then we come to the UTD scan, the UTD risk stratification, in which if there is calicial dilatation or you find parenchymal thickening, you know the risk is increased. And more the symptoms you get in the antenatal scan, more the chance of the complications happening later in life. And do not forget to look for other systems which may be involved simultaneously. Okay, then let's come to the second case. We have a second trimester anomaly scan in this lady who shows a bilateral hydronephrosis in the features. The APD of the renal pelvis is 9 mm on the left side and 11 mm on the right side. The AFI that we just have talked about is 8. So we have just seen that the AFI should be between 8 to 25. So it is 8, so just lower limit of normal, almost we can call it as oligohydramnios. The MVP, which is the mean vertical pocket, is 2 cm, which is borderline. No other major organ anomalies. The lady in question has been referred to the pediatric nephrologist for counseling because her parents and obstetricians want an opinion regarding MG. Okay, so this is the antenatal scan. As you can see, we have just discussed that you can see these are the kidneys, this is the bladder, this is the proximal urethra, and these are the 2 kidneys. Okay, so my question now to Vijay Lakshmi is, how do you approach a case of antenatally diagnosed hydronephrosis?
Yes, ma'am. So already we need to counsel the parents regarding this severity of the disease. Is I think it's more than 7 mm. Usually after 28 weeks, the grading is more 7 to 10, 10 to 15, and more than 15, mild, moderate, and severe. There is a moderate variety, and that amniotic fluid is in the.
I think let's keep it short. I think first thing is Ran, can you just say about how to approach if it's a case of bilateral hydronephrosis?
So, if it is after doing the ultrasound, if it suggests that there is a bilateral hydronephrosis or there is access or there is ureter dilatation or and significant hydronephrosis means there is the APD diameter is more than 10. So you have to suspect that there is no lower urinary tract obstruction. So you have to do a micturating cystourethrogram. And if micturating cystourethrogram doesn't show any vesiculated reflux, then you have to go for the upper tract obstruction, like the EC scan or the ADPS scan.
Yeah, so basically when the patient comes to you antenatally, you have to ensure that this child, his mother is followed up very frequently. So you have to do the scans very frequently, every 4 to 6 weeks, to see how much it is progressing. And once the baby is born, then we accordingly follow up depending on what we find in the last trimester scan and after the baby is born. So we have a newborn now who has a palpable abdominal mass with ascites. The child, because the child had, the baby had oligohydramnios, the features, so we have RDS from pulmonary hypoplasia. There is dribbling, there is poor urinary stream, and this child has renal insufficiency. So here we are. So Vijay Lakshmi, how will you manage this baby postnatally, just in the neonatal period?
Yes, ma'am, thank you. When the child is very sick now,
so we kind of know, we can suspect from the previous ultrasound that this child is probably suffering from lower urinary tract obstruction, most likely to be a posterior urethral valve, because you had seen that the posterior urethra was glossy dilated.
Yes, ma'am.
Right? Okay, so carry on.
So we need to tabulate the child fat in the form of airway breathing and circulation and another metabolic disorder. After tabulation, we need to decompress the bladder by putting a inhaled catheter or a suprapelvic catheter. Once the child is little bit of stable, we need to confirm the diagnosis by doing the ultrasound and the NCG scan and other parameters like electrolyte and ABG. So once confirm the diagnosis, then we need to, when child is little bit of stabilized, we need to go for the definitive management like cystoscopic ablation. If child is still not stable or small, very too small to do the cystoscopic valve ablation, we can do a temporary vasectomy diversion and followed by once child is stable or gain weight, after that we can do a definitive ablation. And after that we need to counsel the parents that there is a possibility of neurogenic bladder and the repeat valve ablation after the residual valve again work.
Right, so the most important take-home message should be that once the valve is fulgurated, does not mean the end of treatment. It is the beginning of treatment. So once a baby has a valve bladder, this child will need a very, very long-term follow-up and management. So Rana, can you tell me about the long-term follow-up and management of this child?
So whatever the treatment this child has required, this child is already at risk of developing CKD. So it has been seen that approximately 60% of the children of posterior urethral valve ultimately develop CKD. So they need a multidisciplinary long-term follow-up at regular interval. First and foremost thing, as Vijayalakshmi already told, that there is a recheck cystoscopy around 3 months of age, just to make sure that the adequacy of the treatment has been done. If required, they need review of fulguration. Subsequently, the follow-up will depend upon the few things, according to the renal parameters, renal function, and how the bladder dysfunction is there, any bladder dysfunction. And the parameters we look usually as the voiding diary, uroplometry, and MPS. That will help us in determining that how frequent these children will need follow-up and what are the next steps in management. So basically, the aim is to prevent UTI, to prevent upper tract more efflux and prevent renal scar development, and at the same time preserving renal function, and if there is any voiding dysfunction, management of that voiding dysfunction. So the baseline treatment for the voiding dysfunction is general urotherapy, which is include the time voiding, double voiding, and improvement of the toilet training. And some of the children, most of the children will need at some stage intermittent tensile catheterization. They need lots of medication like alpha blocker, anticholinergic, just to increase the bladder compliance, increase bladder capacity, reduce the overactivity, and also encourage the adequate bladder emptying. If those doesn't help, some children progressively need botulinum toxin and bladder augmentation surgery. So the aim is to prevent progressive renal damage, at the same time a healthy functioning lower urinary tract. But unfortunately, to all these measures, around 21% children can progress to end-stage renal disease. So they will need at some stage dialysis and transplant, but as discussed yesterday, that before transplant you have to always make sure that the bladder is at least to some extent healthy to complement that.
Yes, so I think again the take-home message is do not leave these children without a very, very rigid and robust follow-up. Okay, next case. Antenatal examination revealed a left kidney which is enlarged with multiple cysts. The right kidney is normal. The postnatal USG at 1 week of life shows the left kidney is 5.4 cm in length. multiple cysts ranging from 0.5 to 2 cm in diameter. Right kidney is 4 cm in length, normal appearance. They have reported this patient as a polycystic kidney disease. And this is the ultrasound. This is a possible ultrasound that you can see. So, Swarni, what are the common associations of cystic disease of kidney? When do you think whatever is reported as polycystic or cystic is true? And how do you differentiate them from the USG?
So cystic kidney diseases in pediatric patients always needs to be looked with caution, because generally most of them are either inherited, they are celiopathies or dysplastic kidney, and a majority of them are part of the polycystic kidney disease spectrum. The patient described here appears to be a multicystic dysplastic kidney, because generally in multicystic dysplastic kidney the entire reniform architecture is disturbed. There would be multiple enlarged cysts. It's like a bunch of grape appearance with no complicating areas in between, and on a functional scan we can find there is minimal to no residual kidney function, and generally these kidneys also have a compensatory enlargement of the other opposite normal kidney, and there could be an association with additional anomalies in terms of VUR or structural obstruction in the other kidney. The other types could be an ARP kidney, which is presenting in the neonatal age group more commonly, where the kidneys would be bilaterally enlarged, echogenic kidneys with impairment of the corticomedullary differentiation. Here the cysts are generally small and generally it gives a salt and pepper appearance, whereas APNEICON is generally seen in an older age group, where there will be a definite strong family history in the parents or the grandparents, and then other types would be nephronophthisis with a smaller kidney, APKD again presenting in the later age group with a smaller kidney, and there could be a part of the cystic dysplasias which are resulting from obstructions or other anomalies.
Yeah, I think so. Again, the take-home message should be whether it's unilateral or bilateral. If it's a syndromic, it's a genetic condition like ARPKD or ADPKD, it is always likely to be bilateral. But for word of caution, ADPKD sometimes can present unilaterally initially and become bilateral later, because both the kidneys may not be equally affected at the same time. But ARPKD will always have bilateral effects. So in the patient that we had, it was a unilateral affection. So this child should not be called a polycystic kidney. So remember that. If it's not bilateral, it is not polycystic kidney, as we call it. So if this is likely to be a multicystic dysplasia, as Swarni just said. Okay. So let's come to the next case. A 30 weeks antenatal ultrasound shows bilateral enlarged hyperechoic kidneys with loss of corticomedullary differentiation. There is moderate oligohydramnias, and this patient also has come to you for antenatal counseling. My question to Shalini. Now, how will you discuss the approach to echogenic kidneys in very short?
Yeah. So, if we have the diagnosis of hyperechoic kidney on fetal ultrasound, we have to understand that the cyst could be submillimetric, and there is a transfer of ultrasound scan from the interface. And so for that we need to see the detailed anatomy in ultrasound, whether the kidneys or genitourinary system, how are they, whether there is presence or absence of renal cyst, what is the location of the kidney, what is the size of the kidney, and other renal and urinary tract anomalies. In addition, we also need to see the amniotic fluid volume. The patient in discussion had oligohydramnias, and we also need to see the extrarenal anomalies. And after that, we could consider MRI, where there are oligohydramnios or anhydramnios, because the fetal anomalies cannot be seen better in ultrasound. And other modality are radiotherapy, radiation defect could be there. And we should also see the extrarenal anomalies, especially the CNS. And if optimal DUST is injured by fetal position or maternal habitus. And we should also consider parental renal ultrasound. So
the other thing is that these, as you said, that most of these patients who have echogenic kidneys, it may not be an isolated problem, or it may be associated with some kind of a syndromic thing. So that is the reason you see the parents also. So just a small differential diagnosis of fetal hyperechoic kidney. Shalini?
Yeah. So we have to understand that it could be physiological variation. Then, if it is not that, then it could be isolated hyperechoic kidney or it could be non-isolated. So in isolated hyperechogenic kidney, it could be ADPKD, which is quite rare, but still it is there antenatally, it could be discovered, and the fetal size is 2 to 3 standard deviation more than the expected for this patient. ARPKD is a classic example of hyperechogenic kidney, where the kidneys are in a 3 to 4 times of the standard deviation. Then in addition, there could be congenital nephrotic syndrome, there could be renal vein thrombosis, and HNF1 beta mutation. It is one of the most common causes of hyperechogenic kidney, and in addition, obstructive uropathy. In non-isolated cases, aneuploidy, which could be trisomy 13, which is most common, trisomy 18, and also trisomy 21. In addition, the infectious causes could be CMV infection or Candida infection, then Necker-Gruber syndrome and other seriopathies could also be the cause. And in monogenic disorders, usually they present with overgrowth syndrome, and in that Davis-Whitman syndrome, Perlman syndrome, and the Simpson-Gulabi syndrome are quite important.
Right. So now we come. So now we're getting into genetics. So we can see that a lot of genetic disorders can also present with hyperechoic kidneys or cystic dysplasias. Now, what is the role of genetics in cattle, and which other systems do you think are commonly associated?
So nephrogenesis is a complex process which is closely regulated by the interacting genes and the signaling process. So any mutation of the genes cause disruption signaling pathway and cause cattle. It has shown that nearly less than 30% cases of the cattle are genetically inherited. It is a complex process again, but it's more common in higher in the bilateral and syndromic cattle compared to the unilateral involvement or isolated cases, non-syndromic cases. Multi-system involvement in SIM, and one thing I should mention is already mentioned by Shalini is the monogenic cattle, where important genes are like PAX and HNF1 beta. Almost every system is involved in cattle. Almost every system is involved, including central nervous system, cardiovascular, musculoskeletal system, eye, ENT, and also other systems like gastrointestinal is also involved.
Yes, so this is the take home that just when you see the patient has come to you as a nephrologist, just see the kidneys. If you can point out some other involvement of other systems, your diagnosis becomes easier. Okay, so we also have a lot of cattle who do not present antennae. They are not, either they are missed or they do not present, the ultrasounds do not show abnormality when they are in the antenatal period. So they present later on. So my question to Shalini is, what are the common presentations of cattle disorders which are not detected antenatally? So just in very brief, just in one line tell me.
So most common is recurrent UTI or palpable masses, or they can mostly they are missed and they are incidentally diagnosed on imaging, and most of them present in adolescent age group as CKD or renal insufficiency. One of the most important findings is growth failure or failure to study.
Yes. Okay, we'll go really fast. Case 5 is a 3-month-old male child presented with poor feeding followed by fever and vomiting. So no antenatal scans in this child. Routine investigations reveal urinary tract infection, as you can see, and the ultrasound AP showed a right kidney AP diameter of 4.5, left kidney 5 cm, a normal dilatation, but a PVR, that's a post-void residue of 12 cc, antenatal scans were normal. Because of this urine infection, post-treatment, MCG was done, and this is what you see in the MCG. So as you can see, there is a VUR. So, Swani, can you tell me about the incidence of primary and secondary VUR in association with other renal anomalies, if you have any?
So in the general pediatric population, different studies have reported incidences varying from 1 to 10%, whereas the incidence is much higher in children having UTI, so it can be up to 20 to 40%, most of your patients having recurrent UTI. And typically there is a familial clustering, so if your parents have it, you have a 1/3 to half chance of having it, and in siblings there is 25 to 33% chance of having that. In the initial period, there is more chances in male, again the ratio becomes balanced later on in life, and the age distribution gradually, because 10 to 15% resolution rate is seen in each year, so it keeps on decreasing. Secondary BUR is mostly resulting from obstructions like PUDs or obstructive disorder in urinary bladder, and other associations could be with multisystemic diseases, or there could be association with multisystemic kidney disease, multisystem dysplastic kidneys, there could be renal hypoplasia, agenesis, osteokidney, which can be also associated with BURs.
Yes. So, what are the guidelines for management of primary BUR, Shalini?
After ruling out neurogenic and obstructive bladder, we name it as standard BUR, and if it is low rate, we have to see whether the patient has UTI or not. If UTI is there, then we have to rule out bladder bowel dysfunction, and if it is with DVD, then we have to put the child on antibiotic prophylaxis. For high grade, irrespective of the presence of DVD, we have to put the child on antibiotic prophylaxis, and if it is recurrent UTI, on APP or with or without DVD, then we can consider for directly reimplantation and endoscopic injection. But antibiotic prophylaxis is required for infants, and when to stop the antibiotic, we have guidelines for that, and surgical intervention is considered in children with recurrent UTI, and of course on parental preferences.
Yeah, so the take home message again is that we are going away from antibiotic prophylaxis than previously. So if it's a high grade BUR, 3 to 5, definitely antibiotic prophylaxis. Low grade BUR, if there is no UTI, no antibiotic prophylaxis. If there is recurrent UTI or there is bowel bladder dysfunction, very, very important, then put the child on antibiotic prophylaxis. Okay, so apart from, we have more or less touched upon the most common and the life-threatening, long-term, kidney-threatening, as you can say, problems that we can face with caput. We'll just touch upon a few anatomical anomalies of development, and just to give you a primer. So this is unilateral renal agenesis. Okay, so my question to Ms. Vanit, can you just touch upon like how to screen these patients and what you should not do? What we have done, what I have showed you is something we should not do.
Yeah, so basically for unilateral renal agenesis, a good renal ultrasound is sufficient. It is going to show a complete absence of renal tissue in the fossa, and there will be a compensatory hypertrophy on the other side. If at all we require, we can do a functional assessment, and generally we also can look for any anomalies if we can see in the contralateral kidney, because there is a chance of BUR. So in that case, we can sometimes go for an MCUG or a PCUG, but CT IUD is generally never recommended because of radiation risk and risk of contrast.
Yes. So this is very important. Then we come to duplex systems. 1 year old 10-month-old child presented with recurrent UTI, USG, we should hydronephrosis, MCUG, duplex system. What do you do next? Vijay Lakshmi?
Yes, ma'am. This is a picture showing the duplex general system with hydronephrosis and fever. So first we need to confirm the diagnosis by doing already ultrasound, and if there is ruled out any other system, we need to do a CT scan and DMS scan for a non-functional tissue or ultrasound. Then we need to see if it is at least symptomatic or asymptomatic. If it is asymptomatic, already there is severe hydronephrosis, it will not be symptomatic. So then we need to treat if there is an recurrent UTI, or to put antibiotic prophylaxis according to the rating of the first.
Yeah, so you just discussed. So this child has a horseshoe kidney. This is very common. Horseshoe kidneys are, I think, one of the most common presentations anomalies. Rana, would you do anything? What do you look out for? Any complications that you tell the parents?
The horseshoe kidney itself doesn't cause any problem with the kidney function, but they are at risk of developing some complications, like as shown in the ureteropelvic junction obstruction. They are prone to develop some stones, nephrocytosis.
Yes, yeah. So if there is asymptomatic, you have any of these complications, surgical, then we Otherwise, if they are asymptomatic, we need not do, just follow them up. Okay. Similar, with ectopic kidneys, Vijay Lakshmi, would you do anything? Incidentally diagnosed?
We need to confirm that already we have some ectopic kidney. So we need to see if there is any other association or not. Like non-functional renal tissue, any obstruction, any BUR. The child is symptomatic or not. If symptomatic, we need to treat accordingly. If asymptomatic, we need to monitor the child every 6 months to 12 monthly by urine purification ratio, ultrasound, and creatinine and growth monitoring and blood pressure monitoring.
Right. So in summary, we can say that the routine use of antenatal ultrasound has led to a lot of really early diagnosis of caput, and which have postnatal consequences. Early diagnosis has helped us to initiate interventions and leading to better outcomes. The ability to counsel parents and make preparations for delivery is very important, and the delivery at the right places where managing the newborns is conducted at a proper strategical way. But still we have a lot of things which are remaining uncovered about the genetic and the environmental regulators of kidney and large tract development. And we can advance the understanding of these caput anomalies by future model systems. We have what we call now organoids, in which a kidney tissue is artificially developed, and these cells are induced with specific challenges and insults. And this can validate the genetic and the environmental contributions to caput. And we can know more about what causes caput in the first place. Okay, thank you so much. Much more left to explain. A big thank you to my panelists.
Thank you, ma'am. Thank you all the panelists. I will request all the panelists and ma'am to come for the memento presentation. I will request Gopal sir and Om sir to please give the memento to the panelists and the speaker. Yes. Moving on next, we have a scientific session. I will request the chairperson, Dr. Anil Kumar Tiwari sir, the Associate Professor, Patna Medical College Hospital, in charge of NRC and COE PMCH, ex-ED member from CIAP Bihar, and keen interest in pediatric nutrition. I welcome you, sir. Next, we have Dr. Hima Charan ma'am. Sir is a ma'am is the HOD Pediatrics, Kurdi Holy Family Hospital. I welcome you, ma'am. And Dr. Rasmi Agarwal ma'am. Ma'am is the Associate Professor Pediatrics, NMCH, and ma'am is the Honorary Secretary, Central IAP, Bihar IAP. Welcome you, ma'am. And for this session, I welcome Dr. Meeta Paul, ma'am, as a speaker.
So, a very good morning to all of you present here, and I welcome our speaker, Dr. Meeta Paul, who's from Ranchi. So, ma'am is consultant pediatric nephrologist at ANBI Newborn and Child Hospital, Ranchi. UTI, nephrotic syndrome, being very close to her heart. And we are going to have an important discussion on UTI in children. Why it holds so much of importance is because the age group that we are dealing with. So probably the symptoms that we have for UTI in terms of frequency, burning and other issues. So the children are not able to communicate that well. And the second issue and dilemma comes to us when we have to diagnose. So the culture, it's very difficult to collect the specimen. So with these things in mind, I would request Dr. Meeta Gogoi ma'am to go ahead.
Good morning, all of you. So, let's identify red flag signs in a child with UTI. Now, for such a common and simple looking morbidity like urinary tract infection, why do we need to identify red flag signs?
those who require further investigation also not investigated for UTI, not investigated further for UTI. Causes being many a times they are not advised. Sometimes the specialized investigations are not available in the town or city where the parents of the child resides, and non-compliance is of course an important point. So in patients who are investigated for UTI, 40 to 50% neonates show BUR, 30 to 40% children show BUR, 10% boys show obstructive lesions, 20 to 40% children with UTI and BUR has renal scarring, and 5 to 10% children progress to ESR. The incidence is so high among investigated children. So we insist for further investigations, specialized investigations, of course guidelines are there. Now, if a child of urinary tract infection presents with fever which is more than 59 degrees centigrade with chills and rigor, if the child is lethargic and sick looking, if he has vomiting, dehydration, refusal to feed, flank pain, all these indicate renal parenchymal involvement, and the child should be treated promptly. If the urinary tract infection is associated with hematuria, urolithiasis must be ruled out. Sometimes children come with repeated episodes of symptomatic UTI. In such conditions, we must check for constipation, bladder bowel dysfunction, some congenital anomalies of genitourinary tract like aerial adhesions, VUR, obstruction of urinary tract, neurogenic bladder, because in all these conditions there is significant amount of post-void residual urine. And this post-void residual urine acts as source of infection for this recurrent infection. Urgency, frequency, squatting. These point towards voiding dysfunction. Again, the child should be investigated accordingly. Dysuria, frequent voiding, hypogastric pain point towards cystitis. Urgency, hesitancy, enuresis diurnal as well as nocturnal. Voiding in an interrupted manner indicate towards discoordinated bladder, and these children must be investigated with urodynamic studies. All toilet-trained children with urinary tract infection must be evaluated for bladder bowel dysfunction. Also, any symptomatic UTI in a patient treated for BUR, urine culture and prompt and aggressive treatment must be done. Children with breakthrough UTI, DMSS scan to check for a new scar. During clinical examination, if the kidney is palpable, it indicates obstructive uropathy. If the renal anal tenderness is there, pyelonephritis is most likely. Palpable bladder, suprapubic tenderness indicates again obstructive lesion. Palpable fecally indicates constipation. Sacral dimple, tuft of hair, lipoma, abnormal neurogenic evaluation of lower limbs, abnormal perineal sensation, all these point towards occult meningomyelocele, and the child must be investigated in these lines. Sometimes even asymptomatic bacteriuria needs treatment if there is any pending urological procedure. Persistent proteinuria after successful treatment of UTI, elevated serum creatinine, all these indicate renal parenchymal involvement, and treatment must be prompt and in this line. Sometimes in urine culture we get organisms other than E. coli. If in patients with urinary stresses, malformations, dysfunctions in the urinary tract, we get urea-secreting organisms like Proteus, Klebsiella. These patients are at risk of developing hyperammonemia and encephalopathy. This is because the venous drainage of urinary bladder drains directly to the systemic circulation. It bypasses liver. So the ammonia which is formed cannot be detoxified, and it enters the systemic circulation, and through systemic circulation it reaches brain. And these children are at risk of developing encephalopathy. So if we are getting urea-secreting organisms in urine culture, they must be treated aggressively. In patients on immunosuppressive agents, patients on broad-spectrum antibiotics, or when intravenous line bladder catheter are kept for prolonged periods, sometimes we get fungal UTI. Fungal UTI is confirmed by the presence of pseudohyphae in the urinary sediment. In fungal UTI, there can be formation of fungal balls causing obstruction and at times ARF event. So if we are getting fungal UTI, they also should be aggressively treated. Though uncommon in children, at times we get sterile pyuria, persistent hematuria, persistent leukocyturia. If these findings are in line with other clinical features, then renal tuberculosis should also be considered and investigated and treated accordingly. If ultrasound is abnormal, in a child with first episode of UTI and even without any sign of toxicity, if ultrasound is abnormal, they must be further investigated with NCU and DMSS scan. If there is hydronephrosis without VUR, then again we must think in terms of PUG obstruction, and the DTPS scan should be done to assess renal function. Sometimes we do not get treatment as per, do not get the result of treatment. Failure of response to treatment. Most common causes are non-compliance and non-sensitivity of the pathogens to the drugs. But if these two are ruled out, then we must think in terms of whether there is a presence of any complicating factors or not, which are already been described in the previous slides. Thank you.
Thank you, madam. Thanks for your very informative talk. Dr. Meeta Paul happens, my senior at the Patna Medical College. So we have some time left during her presentation, so we may invite 3 questions if anybody wants to ask any question from, because this is a very important topic and very common problem in pediatric patients particularly, and if not diagnosed properly or if not suspected in right time, the situation may worsen, leading to kidney failure and so many problems for the future. So we must suspect UTI in every right patient, and particularly in newborn baby and in baby less than 3 months of age is very important. So any patient please, otherwise we may take jointly, because the next session is also on the similar topic of red flags in UTI, that is also very important when we should suspect. Thank you, madam. Okay.
Up to what age we should continue immunosuppression?
Immunosuppression.
Antibacterial prophylaxis. Antibacterial prophylaxis.
Yes.
Up to what age we should continue?
Antibiotic prophylaxis these days are advised only for VUR grade 3 or 4 or 5 rather. In VUR, vesicoureteral reflux 1 and grade 1 and 2 also, if it is not associated with bladder bowel dysfunction, then it is antibiotic prophylaxis is not required. It is not recommended basis.
To what age it should continue, and what are the urinary findings after which we can level that we should not continue any further antibiotic prophylaxis? Is there any such guideline? If there is, you can speak.
Yes. Only in case of VUR, because in urinary tract infection as such, we do not recommend antibiotic prophylaxis unless and until it is associated with some complication. Like if the bladder bowel dysfunction is not there, then we can discontinue. And if in VUR also, if there is 1 year after antibiotic prophylaxis, there is no UTI after till 1 year, then we can discontinue antibiotic prophylaxis.
Okay, thank you, madam. I will request Dr. Hima to invite next speaker.
Dr. Arpita, please. I welcome Dr. Arpita Gogoi ma'am from Dibrugarh, Assam. She is the Associate Professor and PICU in charge, Department of Pediatrics, Institute of Assam Medical College, Dibrugarh, Assam, almost having 20 publications to her merit and has made many awards and professional achievements. Welcome ma'am to our state. Your talk, please. Thank you.
A very good morning to everyone. At the outset, I would like to thank the organizers for giving me this opportunity to present this topic at this August gathering. I shall be speaking on investigating a child with UTI, striking the right balance. So UTI, as you all know, is defined by the growth of a significant number of organisms of a single species in the urine in the presence of symptoms. So the presence of symptoms is important because we don't want to treat asymptomatic bacteriuria. It is one of the most common bacterial infections in children. In febrile infants, the prevalence is as high as 7%. Around 1/3 of all patients with the first episode of UTI may have underlying urinary tract abnormalities. There is a 10 to 30% risk of recurrent UTI in such children, and also some risk of long-term kidney damage. So if we look at the classification, it can be classified into cystitis, which is lower tract symptoms, and pyelonephritis, which is upper tract involvement. Based on symptoms, it can be either asymptomatic bacteriuria or symptomatic UTI, and based on the presence or absence of complicating factors. The diagnosis depends chiefly on symptoms, the urinalysis evaluation, and the urine culture. Clinical features are non-specific, especially in small children and infants with fever, vomiting, lethargy, poor feeding, irritability, or even prolonged urinary jaundice. In older children, upper tract involvement could lead to fever, hematuria, lethargy, and lower tract involvement could lead to local symptoms like abdominal pain, loin pain, tenderness, incontinence, frequency, dysuria, etc. So this is the same thing which has been depicted. So more local symptoms in lower tract UTI and more upper generalized symptoms in upper tract UTI. So as far as the topic of my presentation goes, how to investigate a child with UTI. First, we need to investigate to establish the diagnosis of UTI in the form of urinalysis, urine culture, and blood draw only if needed. And secondly, to investigate to diagnose the underlying causes and effects of the UTI, which is where the role of ultrasound, intubating cystourine and DMSC radionuclide scan comes to rule out VUR and renal scarring respectively. So coming to the diagnosis of UTI, the method of urine collection is of paramount importance. In non-toilet trained stable children, we should initially attempt to collect a clean cat sample by maneuvers like the quick wee technique, where some stimulation is given on the lower pelvic area while trying to catch the urine, but this may take a long amount of time. So if you fail to do this, then either a clean catheterization or a suprapubic aspirate, especially for children who are admitted to ICU and sick children, this may be attempted. And for older children, the gold standard, those who are toilet trained, the best way to collect is by taking a clean catch midstream urine. However, in any case, the urine lab sample is to be strictly discouraged. So after collecting the urine, we have to just grossly look at the urine to see if the color, if there is a high colored urine or foul smelling urine, then we may have some doubt that there may be UTI. But the ISPN 2023 guidelines support the use of dipsticks, that is the leukocyte esterase and the nitrite tests to presumptively diagnose UTI and start treatment while we send and await the culture response. So the nitrite and leukocyte esterase tests both together have a high sensitivity and specificity to determine whether the UTI is present, and this when combined with leukocyturia and bacteriuria in the urine further strengthens our suspicion of UTI. Significant leukocyturia in a freshly passed uncentrifuged sample is WBC more than 10 per millimeter cube or more than 5 per high power field in a centrifuge sample of urine. And 1 bacteria per 10 oil immersion fields of fresh uncentrifuged sample can be said to be bacteriuria. So as per ISPN, urine culture is a must for diagnosing UTI. However, leukocyte esterase and nitrite is as good as microscopy for presumptive diagnosis. So, to diagnose UTI in children, in the presence of appropriate clinical context, that is presence of symptoms, the significant growth of a single uropathogen is important. And if it is a mixed flora, then we may need to repeat the urine culture because that may indicate contamination. So, what is significant growth? In case of suprapubic aspiration, more than or equal to 10 raised to 3 colony forming units per ml. In case of catheterized sample, more than or equal to 10 raised to 4. And in case of clean cat specimen, more than or equal to 10 raised to 4 to 5. So earlier guidelines, when 2011 guidelines say 10 raised to 5, but now the cutoff has been lowered, the threshold has been lowered to also include 10 raised to 4, because it has been seen that if you keep the higher cutoff, then almost 20% of all UTIs will be missed, especially in young children. Hence, the cutoff has been lowered. So now coming to it, I don't think we need to discuss this in detail again, because Meeta has already discussed. So now what are the goals of treatment in UTI? We need to eliminate infection and prevent urosepsis, need to relieve the acute symptoms like fever, dysuria and frequency, and prevent recurrence and long-term complications. So what are the indications for hospitalization of a child with UTI? If the age is less than 2 months, if there is a suspicion of urosepsis clinically in the form of toxicity, hypotension, features of shock, etc., if there is vomiting or inability to tolerate oral medications, if the child is immunocompromised, if there is a lack of adequate outpatient follow-up, and if there is a failure to respond to outpatient therapy. So as per ISPN guidelines, we need to start treatment as soon as possible after presumptive diagnosis of UTI, within 48 to 72 hours of fever. The longer you take to start the antibiotics, the more the chances of renal scarring later on. So oral antibiotics for acute pyelonephritis can be as good as IV medication, except for few instances like infants less than 1 month, children with bacteremia, sepsis or inability to take oral medication. For cystitis, a short course of 3 to 5 days is as good as a longer course, and for pyelonephritis, around 7 to 10 days of antibiotics is advocated. So this is the gist of the treatment of UTI. Cystitis, oral antibiotics for 3 to 5 days. Pyelonephritis in younger children, sepsis, poor oral intake. Then oral, if these are not present, then oral antibiotics can also be given. And if these are present, then IV antibiotics for the initial 2 to 3 days, after which once the child stabilizes, we can move over to oral antibiotics. If there is clinical response, then the total duration of antibiotics would be 7 to 10 days. If there is no clinical response within 48 hours, then we need to repeat the urine culture and an ultrasound to look for structural abnormalities which may prevent resolution of symptoms. So now coming to the investigation after an episode of UTI. So the strategy for the last almost 4 decades has been to protect the kidneys from further damage after an initial attack of UTI and to detect childhood genitourinary abnormalities which lead to an increased incidence of UTI and also lead to increased scarring. The strategy was also to prevent recurrence of UTI by giving continuous antibiotic prophylaxis. The most common anomaly, as we know, 30 to 40% of UTIs especially in the younger age group, have an underlying VUR. So an NCU was advocated in almost all cases of young infants to rule out VUR. And if there was a VUR, continuous antibiotic prophylaxis was suggested with surgical intervention if antibiotic prophylaxis was not helpful or in cases of high-grade VUR. So this was the traditional concept that we needed to prevent renal scarring at any cost. in order to prevent end-stage renal disease, hypertension, preeclampsia, etc. So prophylactic antibiotics would be given to prevent recurrences of UTI and surgery to correct VUR if needed. However, there has been recently a paradigm shift in the understanding of why chronic kidney disease occurs secondary to UTI. So these may actually be less likely due to the UTI per se, but due to some kind of dysplasia of the kidneys which are pre-existing, which may also predispose to VUR, which is causing the scarring actually, and not the recurrent UTIs. So 15% of children with first episode of UTI on follow-up scanning do have evidence of renal scarring. Scarring would be clinically important if it led to hypertension or CKD, but if it is not actually leading to CKD, then we do not need to be so dogmatic in pursuing an invasive procedure to rule out presence of VUR in all cases. So hence, the current understanding is that VUR and PVD are the bowel bladder dysfunction are the commonest causes of recurrent UTIs, and the kidney damage is caused chiefly by congenital dysplasia rather than acquired scarring secondary to UTI. Hence, and also surgical correction of vesico-ureteric reflux does not really lead to an actual lack of decline in kidney scarring and CKD, which has been found in recent studies. And overall, the risk of ESKD in all children with VUR is very low. Hence, there is a significant change in practices in evaluation and management of children with UTI. Thus, a less aggressive approach is now being advocated for imaging, as the available interventions to correct the abnormalities do not impact the outcome significantly. So what is the use of finding out that whether VUR is there or not if the interventions are not going to help the eventual kidney scarring? That is the thought. And it is not necessary to expose each and every child with UTI to invasive investigations and radiation. So now the guidelines suggest, the ISKN 2021 guidelines suggest that after the first episode of UTI, all children must undergo an ultrasonography. If the child is very critically sick, not getting well in 48 hours, then we may do the ultrasound right during the episode of UTI, but we may also wait for a child who is responding to treatment. We may wait for some time, 2 to 3 weeks before doing an ultrasound. If the ultrasound is abnormal in any way, like if there is a hydronephrosis or a thickened bladder wall, etc., then we have to go for a micturating cystourethropy in that child. Secondly, if there is a non-E. coli UTI in less than 2 years of age, because these children are more likely to have underlying anomalies, as Madam Meeta said already, or if a child has recurrent UTI. Recurrent UTI is any episode of UTI which is occurring for a second time, irrespective of the time duration. So in these cases, that is abnormal ultrasound, non-E. coli UTI less than 2 years, and recurrent UTI, we must go for an MCU to detect structural abnormalities. And if the MCU is detecting high-grade VUR, that is grade 3, 4 and 5 VUR, or if there is an episode of recurrent UTIs irrespective of MCU findings, we need to do a DMSA after 4 to 6 months to determine whether there has been renal scarring. So this is the current guideline for evaluation of UTI, which is much less invasive than the earlier guidelines, where less than 1 year old all children needed to have an ultrasound, an MCU and a DMSA. Then a child 1 to 5 years needed to have an ultrasound and an MCU. So those things have been reduced now. So ultrasound for all patients, it is non-invasive, no radiation exposure. However, it is operator dependent. MCU, as I already said, abnormal ultrasound, patients less than 2 years with non-E. coli UTI and patients with recurrent UTI. The problem here is that there is radiation exposure. It needs catheterization, and there is a small risk of UTI due to the catheterization itself. However, it is the gold standard for diagnosis of VUR, and it provides a detailed anatomical delineation of the urinary tract. These are the advantages. And late phase DMSA scintigraphy after 4 to 6 months in case of recurrent UTI as well as high-grade VUR, because this is the gold standard for detecting kidney scars. However, there is a risk of radiation exposure, and sometimes it is not very easily accessible, and it is also an invasive procedure. So recurrent UTI, as I said, is occurrence of 2 or more episodes of UTI in a child in any time period, and around 30% of all children experience a recurrence of UTI in the next 6 to 12 months, with these being the risk factors. Age less than 1 year, girls, uncircumcised, boys, poor fluid intake, structural abnormalities, BBD, etc. So we can skip the BBD slides, I think. So another important thing is the vesico-ureteric reflux. which is the retrograde flow of urine from the bladder to the upper urinary tract, which is presumed to arise from an abnormal urinary bud formation, which is also an important risk factor for UTI and recurrence of UTI. And incidence is estimated to be about 1/3 in children less than 5 years or even higher in the case of infants. So these are the various grades of UTI as per the SFU grading. Now I'll take just a few minutes more. So why is this reflux important? Why is kidney scarring important? Because it is the chief long-term complication of UTI, and around 10 to 15% of febrile UTI patients develop permanent renal scarring on follow-up. High-grade BUR, infection with non-E. coli organisms, high-grade fever, high CRP, and delay in starting antibiotic therapy and an abnormal urinary tract predisposes to renal scarring. So, a word about renal scars. So, there are two types of renal scars. One is a dysplastic scar, which is congenital, which is associated with an overall smaller size kidney, and these scars are symmetrical. Whereas the acquired scars, which are secondary to acquired UTIs, these are small focal defects without a generalized affection of the entire kidney. And it is the congenital scars which are more dangerous in terms of leading to ESKD rather than the acquired scars. And in any case, in all kinds of scars, it is important to start antibiotic therapy within 48 to 72 hours of the onset of symptoms in order to minimize the probability of scarring. So we will not go into details of these. So, in summary, we can say that diagnosis of UTI should be based on culture with a specific focus on the collection method. Dipstick leukocyte and nitrite screening can form initial management while awaiting culture confirmation. Oral antibiotics as well as parenteral antibiotics. Renal damage can be prevented by prompt treatment of UTI. Only high-risk patients, that is high-grade BUR and BVD patients with recurrent UTI require antibiotic prophylaxis. Patients with BUR rarely require or benefit from surgical intervention. And dysplasia, which is a developmental defect rather than UTI, which is an acquired condition, related scarring results in CKD. So the current recommendations encourage performing radiological investigations only in those children who are at risk and discourage routine prophylactic antibiotic use. And a renal ultrasound should be performed in all febrile infants and young children with UTI. MCU is not routinely done after the first episode of UTI now. And recent evidence supports less aggressive imaging and prophylaxis following uncomplicated UTI. However, further on, targeted research is required to inform knowledge gaps and devise cost-effective care for pediatric UTI. Thank you for your patience.
Thank you. Thank you, Dr. for a very nice presentation on a very common topic, UTI. We must ensure that it is a very common problem in practice in clinical side, and we must investigate it properly. But culture sensitivity is always an issue, because if we go only for supraclinical selection, then it will be of a very good quality. Otherwise, it is up to 50 to 90% anywhere. So we must also ask for nitrite and leukocyte safe testing our prescription specifically, and also ask for proper microscopy to have the glimpse of the diagnosis. And also the stringent aseptic quality of the laboratory should also be maintained. इसमें किस्सा मैं बताता हूँ, जब हम लोग अंडर ग्रेजुएट में थे, हमारे प्रोफेसर मोहन मिश्रा जी का प्रोबेबली हो सकता है मैं भूल रहा हूँ, बताया हुआ है कि एक इंडिया के बहुत अच्छे जो मैंने आदमी यहाँ के थे, पैसा वाले थे, उनका यूनिक सैंपल गया फ्रेंच लेबोरेटरी में, एक ब्रिटिश लेबोरेटरी में गया। दोनों जगह से कल्चर पॉजिटिविटी आया, लेकिन दोनों जगह से 2 ऑर्गेनिज्म आया। अब झंझट हो गया, दोनों अवार्ड में अपना क्लेम कर रहे थे कि मैं बेटर हूँ, झंझट हो गया। हुज रिपोर्ट इज रियली जेन्युइन। उनका था कि हमारे यहाँ ये प्रोटीस आया है, यहाँ ड्रेसिला आया, यही है। उसके बाद तीसरा जगह कराया गया, तो इसराइल आया सैंपल, तो वो जब का झंझट हो गया तो मुश्किल हो गया। तब दोनों जगह सैंपल लिया गया लेबोरेटरी का, तो उसमें वही ग्रोथ आया था जो उनके लेबोरेटरी में बैक्टीरिया ग्रो कर रहा था। So this is also a very burning issue. The quality of the laboratory should also be very proper for this condition. Otherwise, we may go treating in a bizarre way. So thank you very much. Any question?
So,
my question regarding the recurrent UTI, you said that more than one UTI is recurrent. Whether these UTI are febrile or even afebrile UTI, lower UTI also taken?
Yeah, as long as it is symptomatic. It can be either generalized symptoms in the form of fever and toxicity, or it can be localized symptoms like cystitis, like lower tract symptoms. But if it is culture positive along with symptoms, then we take it as a UTI. If there are no symptoms and for some reason the urine culture was done and that was positive, that will not be taken as an episode of UTI, that will be just an asymptomatic bacteriuria. No, fever is not a defect. Fever is for pyelonephritis basically, but UTI can also be cystitis or urethritis, as long as it is culture positive.
So I must congratulate you, Dr. Geeta, for a beautiful presentation. And as has been summarized by Dr. Tiwari sir, we have to be very cautious in UTI, given the end results of the disease not being treated well. So definitely we don't want to go for a renal scarring or ESRD. So all the parameters you have beautifully categorized what we are supposed to do, and Dr. Neeta ma'am, even she very simplified way she chose to project UTI. So thank you so much. With that, we end this session.
Thank you, ma'am, and thank you all the chairpersons. I request you all to please come for the memento presentation. I will request Gopal sir to please assist in the memento presentation. Moving on next, we have a panel discussion moderated by Dr. Anand Gupta sir. I will request, and the panelists Dr. Prince Parekh, Dr. Nilhari Bose, Dr. Sanjukta Buddha, and Dr. Diplov Maji. There is a small announcement for the evening. We have a quiz competition from 4:15 to 5 p.m. by the Mentimeter. I request you all to be here at the time of quiz competition and participate in that. Also, I will request all the speakers to please abide by the time allotted. We have to manage all the speakers, so please, I request you all, and hand over mic to Dr. Anand.
So there is exciting prize also for the quiz. So thank you, Chandan. So greetings from my institute, IGIMS Patna, and so we have a case discussion, and I am happy that Pankaj sir is also there, who has done maximum work in UTI and especially about genetics of VVR. So this presentation is mostly will be a repetition of what previous two talks, so bear with me. So let's introduce our panelists. We have all Bengal panelists. We have all 4 from Bengal. But my institute people also say कि तुमको बिहार में जितना नहीं बुलाता उतना तो बंगाल में बुलाता है प्रोग्राम के लिए. So Bengal is like second home for me. So my first panelist is Dr. Prince Parekh. He was with me during my senior agency attempts. He is chairman and director of Pan Pearl Hospital, Siliguri, and he is the organizing secretary for our next APNEICON at Siliguri in 2026. Second is Dr. Nilhari Bose, who is consultant at Kolkata, Mukundpur Hospital. Next is Dr. Sanjukta Buddha. She is assistant professor at ICH Kolkata. And next is Dr. Diplov Maji, who is from Asansol. So I will not go into introduction, you all have seen. So our first case is a 2-year-old child presented with complaint of fever, dysuria, and increased frequency of urine. So fever symptoms were suggestive of UTI. So he was empirically started on 3rd generation cephalosporin, urine routine microscopy, and culture was sent. At day 4, child is symptomatically better. General physical examination is normal. No positive findings. Bowel habits are normal. but urine culture shows significant growth of E. coli resistant to cefixime, which we are giving. So, my question to Dr. Prince, would this warrant the change of antibiotic?
Well, I won't be changing antibiotic in this child because this child is improving. So perhaps this antibiotic is working in vivo, so there is a in vivo sensitivity. In vitro we are not getting. So we will continue the same antibiotic for a period of maybe 7 days.
So this is very important message that don't treat the patient, not the report. So if the patient is improving, so no, we will not need to change the antibiotic. So any further evaluation, Dr. Prince?
This is E. coli UTI, non-complicated, and at this age, no further evaluation would be actually be needed. Had there been a history of recurrent UTI or other things, then we would have thought for ultrasound, but not required in this case.
Okay. So now case 2. A 2-year-old boy was treated for symptomatic culture positive UTI and completed 7 days of antibiotics. He symptomatically improved, no fever or illness symptoms. His pediatrician repeated his routine urine and culture by batch sample. Urine routine show albumin nil, first cell 1 to 2, urine culture E. coli 10 to the power 5 colony forming unit per ml. So, Dr. Nilagiri, what are the common risk factors for recurrent UTI?
Thank you, Dr. Anand. Thank you, Team Patna, for the opportunity. So I will discuss the common risk factors for recurrent UTI. There are mainly anatomical factors and different post-related factors. But I would like to highlight in female sex where the urethra is shorter and there is proximity to the perineum, uncircumcised boys, families to recurrent UTI and high-grade viewer, constipation and the neurogenic bladder. We should also look for any evidence of DUV, urethral dilated collecting systems, and renal staining is there or not. But most importantly, other than that, different lifestyle issues like toilet training problems, inadequate fluid intake, holding urine or stool for a long time, maybe during the school hours, is very, very important risk factors for recurrent UTI in children.
So, thank you. So, one important point we should remember, in any other body part of the body, if there is recurrent infection, we think of immunosuppression. But kidney is different. In case of recurrent UTI, mostly anatomical defects, which are important. So, what is the ideal method of collecting urine in children, Dr. Nilagiri?
After Arpitaman's talk, now it is very easy and the message has been very clear that back samples are not actually acceptable. It is the best thing is a mainstream clean catch urine sample if feasible. Other than that, if there is expertise and if it is available in very, very small children, we can do a clean catheter in and out sample. But definitely, a back sample is not at all the ideal sample of choice for diagnosing and treating UTI.
So, at maximum, the role of back sample is that negative back sample, we can sure that this cannot be UTI, but positive back culture has very little evidence. So, is circumcision included in male children with recurrent UTI?
Okay, regarding circumcision, there is a very famous meta-analysis which shows that the risk of UTI in normal uncircumcised boys is around 1%, and here the number needed to treat was around 111 was there. That is to prevent one UTI, but the risk becomes tenfolds in children with recurrent UTI or other urinational problems, and there the NNT or the number needed to treat becomes around 10. That is, you have to do at least 10 to prevent 1. So that is very important. The degree of reduction is very, very important for doing circumcision in children with recurrent UTI, and also in children with high-grade viewer. The importance of doing circumcision is much more.
So, these are the other problems of congenital like balanitis, erotica, obliterans, recurrent UTI, and Kapoor can lead to. So, case 3, a 6-year-old female child presented with feature of lower urinary tract infection symptoms and recurrent UTI. She has habitual constipation, does not void in the school, which is a very common phenomenon. So, what are the imaging to be done in child with recurrent UTI, Dr. Sundip sir?
Thank you, Dr. Anand. So coming back to the case scenario, before going for an imaging, I would go for a history and examination for this child also, very important, because improper voiding habit, improper positioning, these are important because the child is having a habitual constipation. During examination, I should be looking at the genitalia of the child. It's a 6-year-old child, so not only level addition, also look for any features of any sexual abuse in this child. Which can lead to recurrent UTI, and also look for an abdominal examination for any fecal. Coming to the imaging part, after any episode of UTI, one should go for an ultrasound. Ultrasound examination will tell you a lot of things, not only anatomical defect, what is the size of the kidney, if there are any complications like there is some abscess or something, if in case of a complicated UTI, what is the bladder thickness, any uteric or AP diameter is increased, uteric cavitation is there, and also look for the transverse rectal diameter, which can give you a clue that the child is having a loaded colon and there is a clue of constipation. And in the next line of investigation, is already discussed by in the last section by Dr. Arpita ma'am, that now in the new ICL guidelines, we have come down in doing NCOG and DMSS scan. So children who are having recurrent episodes of UTI and those who are having some kind of abnormality in their ultrasound scan and having non-E. coli UTI below 2 years of age, they are only supposed to have their NCOG done. And regarding DMSS scan also, a delayed DMSS scan, at least after 4 to 6 months of after an active UTI, one should go for a DMSS scan. And this should also be done in a case where there is some finding in the ultrasound or the NCOG.
Thank you, Dr. So this is the current ICL guidelines that I already told. So USG was done. So this is the findings. So what are the important findings in this ultrasound?
So in the upper urinary tract, it is more or less normal. The kidney size is a little on higher side and but normal echogenicity. The bladder wall is thickened, though it doesn't mention whether the bladder was full or empty, because this bladder wall thickening has to be seen with the filled bladder. If it is more than 2 millimeter, then that is suggestive of increased bladder wall thickening and can be suggestive of an active cystitis or some kind of or there is some lower urinary tract abnormality in this child. And again, coming back to the post-border residue, which is also on higher side, though I would ask the pre-voidal volume of this child also, because more than 20% is suggestive of increased post-border residue, and a loaded rectum is also present, which is suggesting that the child is having an habitual constipation. But I would like to request my radiologist friend to give me the transverse rectal diameter, which can give me a more clear view whether the child is constipated or not, because the families, they often deny the history that the child is having any constipation.
So important point is when we send a requisition for ultrasound, we must write please comment on bladder wall thickness and post-bladder residue. Because in a hurry, mostly radiologists see the kidney size and CMD normal and bladder just normal. So DMSA and MCU were done for this child. So Dr. Biplav, can you explain the findings?
So on the left side of the image, you can see it's an image for a unified scintigraphy. You can see in the image there are multiple photographic areas on both the poles of the left kidney. So DMSS scan has been done to find out if there is scar in the kidney, which is probably secondary to recurrent UTI. And on the other image, you can see there is it's an image for NCOG. Which is the gold standard for diagnosing vesicular reflux and also other anomalies of the urinary tract, like posterior valve, void, and other anomalies. But here in the image, you can see there is no reflux, the bladder contour also looks normal, and there is no posterior valve as well. So the NCG can be reported as normal.
So, what is the reason of recurrent UTI? We have seen already this, but can you explain this?
Yes. So there are multiple risk factors for recurrence of UTI. The most common are VUR, that is vesicular reflux, and BPD, bladder wall dysfunction. In our patient, there was no viewer, as you can see in the MCUG, but there is a different history of bladder wall dysfunction in this child. So bladder and bowel dysfunction usually come in combination. This is because they have common immunological origin as well as similar nerve supply. And if you are considering bladder dysfunction, you should ask for different symptomatology, but some people already discussed about it, like incontinence, frequency, dysuria, hesitancy, and also we should ask for any holding manner, like if the child is crossing the legs and sitting on the sitting from pelvis, also pinching the penis for holding urine. Sometimes the child sit on the toe to prevent on period to prevent holding urination. So these are the different holding manner here, which also predisposes the child to recantation. Regarding bladder dysfunction, bowel dysfunction, we should ask for if the child is passing getting frequent stool, the stool is very hard. Sometimes the child might present with a fissure in ano, very painful implications. Child might avoid going to toilet at a daily basis, and the stool might be very hard. Sometimes the child passes liquid stool in inappropriate places like in school or in pants, which fall into places, and this is also sign of severe constipation. So all these signs and symptoms should be looked for to love the bladder wall dysfunction, which is present in our child.
So, Dr. Prince, can you explain about the very important distal stool chart?
We don't want constipation because it is a known common risk factor for UTI. So I hand over this research chart to all my families the child of whom constipation. So we want a stool of like 4 or 5 type. So we don't want constipation, particularly type 1, type 2, or very loose stool type 6 or type 7. So diarrheal stools would be like type 6 or type 7, and constipated stool will be like 1 or 2. So generally we advise, we want the parents to see whether the stool is of type 4 or type 5. So the laxatives are given, whether we are giving polyethylene, glycol, advising toilet training, but we want type 4 or type 5 types of stools.
So it's very important every pediatrician or pediatric nephrologist must have this stool chart on their table. And ideally, because when we ask the history of constipation, almost everybody says that इसको कोई constipation नहीं रहता है. Sometimes they don't know the meaning of constipation. What actually the child is passing urine in stool daily is not constipation. But by showing this chart, we can reliably diagnose. So, can you explain this voiding, this functional voiding scoring system?
Yes, this is a set of questionnaire 10. The maximum score will be 30. So, after asking these questions, we will just add up and see what is the score. So, in females, it is a score of more than equal to 6 or a score of more than equal to 9. It suggests dysfunctional voiding. Then we may have to go first.
So, how to manage BBD, Dr. Yasmin?
Management of BBD is the crux of treating any recurrent UTI or voiding dysfunction. Because until and unless you treat constipation, there will be recurrence. And constipation is in children, nowadays it's quite common, and it is often missed or not even looked after. And it has to be aided with a bowel and bladder diet. That's why I request everyone to at least urge all the patients that their parents should maintain a good bladder and bowel diet. That will help them and as us as well. For regarding bladder training, there should be until and unless the child is toilet trained, there should be at least 2 to 3 hourly or 4 hourly voiding. Double or triple voiding may also be tried. Squatting and facing problems might be there in obese children. Many times the children they actually try to pee or poop with standing posture. That should not be encouraged, and they should always come. There should be targeting the complete emptying of the bladder. Many times they are in a hurry. They just they don't complete their urination or stool, and they come out of the toilet. And definitely cleaning the external genitalia after micturition and maintaining the local hygiene is very important. As far as the bowel training is important, that is the daily morning stool with adequate amount, maintaining the Bristol stool chart as we have already shown, appropriate positioning, and most importantly, when they are using common or Western style, we should provide some stool or support for the legs. Because if their legs are dangling, so definitely the pelvic muscle will be in stress and complete evacuation won't be achieved. And most importantly, during the school hours, many times we see that the children are not passing their urine or stool, they are holding it. That should be definitely avoided. Even we can many times we write in our prescription. So these things should be addressed with high. This is very important from the beginning of the treatment of recurrent UTI in any children.
So we'll go to our next course. A 3.6-year-old female with grade 4 VUR of left side on regular antibiotic prophylaxis, and she has breakthrough febrile UTI. She was admitted and started on IV antibiotics. So what are the indications of antibiotic prophylaxis and when we can stop? Dr. Sanjukta.
So regarding the antibiotic prophylaxis, the new guidelines, they have mentioned that we should give antibiotic prophylaxis to children with high-grade VUR, that is 3 to 5, to prevent recurrent episodes of UTI, and also to those who are having an underlying BBD or the bladder bowel dysfunction along with recurrent episodes of UTI. But if a child is having recurrent UTI, in spite of whatever is the grade of VUR, even if low grade VUR, if the child is having symptomatic recurrent UTI, then you have to give this antibiotic prophylaxis. Regarding antibiotic prophylaxis, we all of us know about the famous river trial. So it has shown us that it prevents symptomatic UTI, but it has no role in preventing renal scar. Moreover, it increases the chances of antibiotic resistance, but still, as it prevents symptomatic UTI, so antibiotic prophylaxis is recommended, but with specific antibiotics. Below 3 months, usually cefalexin is preferred, and above 3 months, cotrimoxazole or nitrofurantoin is the drug which we give as antibiotic prophylaxis. Nitrofurantoin has GI intolerance issues, though it is better as a prophylactic medication, but cotrimoxazole can be given, but one should check for the GC3 deficiency before prescribing this drug. And regarding stopping the prophylaxis, there are very clear-cut guidelines. A child who is more than 2 years of age and not having any breakthrough febrile UTI on antibiotic prophylaxis over the last 1 year, who is properly toilet trained and is free of any underlying BBD. There we can think of stopping the prophylactic antibiotic.
So our next case is a 2-year-old female presented with high-grade fever and was diagnosed to have UTI. She had right antenatal hydronephrosis which was not followed. USG KOB suggestive of acute right pyelonephritis. UTI treated and started on prophylaxis. Has recurrent breakthrough UTI, no history of constipation. So this was his DMSA and MCU. DMSA shows photoclinic areas in upper bowl of right kidney and MCU shows bilateral grade 4 VUR. So is surgery indicated in this child, Dr. Biplov?
So the indication of surgery in a case of recurrent UTI is when the child having more than two or more febrile UTI in spite of having antibiotic prophylaxis, and already we have addressed the bladder wall dysfunction. So here this child is already been given treatment for BBD as well as antibiotic prophylaxis has been given. So we would like to consider surgery for this child. Now there are two kinds of surgery that we usually recommend. One is implantation that can be done by intravesical extravesical approach and also through laparoscopy or robotic surgery. The choice depends upon the institutional preference as well as the training of the surgeon. And the other kind of surgery is endoscopic deep class injection at the vesicular junction. The rate of recurrence of VUR is less in the first grade, but then the first type of surgery, but then also it is the first type of surgery, that is uterine implantation. The patient needs to stay in the hospital for longer duration, also post-operative complications are there. So it's a patient's choice to go for and to choose for the surgical approach. But also we should discuss adequately with the parents and discuss about in a balanced way that whether we use the antibiotic prophylaxis or the surgical treatment, the ultimate outcome doesn't change. That means the chances of having renal scar or declining in the renal function, which might ultimately land into an ESRD over a follow-up of 5 to 10 years, in both the arms, whether using antibiotic prophylaxis alone or using a surgical treatment, remains same. So it's a parent's choice to choose one of them. But here in this patient, because the child is having recurrent UTI even with antibiotic prophylaxis, we should approach the parents to have a surgical opinion for recurrent UTI. That will reduce the chances of having symptomatic recurrent UTI, but the overall outcome will remain same in long-term period.
Thank you, Dr. Viplo. So this is the last case which I saw just a day before in my OPD, and it has some important message, that's why I have kept it. 1-year-old male child presented with fever without focus and failure to thrive. So his hemoglobin was 11.4, but creatinine was 1.49. So, and urine culture report is showing this. So, Dr. Vince, can you do interpretation of this?
So the persons are 10 to 12, and Pseudomonas is grown in culture, and more than 10 to the power 5. So first, it is very important to ask how the sample was taken, but this is significant. And if you see the sensitivity report, most of the medicines to which the child is sensitive the organism is sensitive. They are all injectables, some of which we are not giving, like tobramycin. So one of these antibiotics have to be started because it is a clear-cut case of UTI, Pseudomonas UTI, and also here the ultrasound further workup has to be done. Another important thing that has to be kept in mind is that the creatinine is high. So whatever antibiotic we are using has to be in renal adjusted doses. That is very, very important. So this is the message.
So ultrasound QB version, Dr. Niladri. So I don't think it's very clear.
QB showed there's a bilateral renal fossa was empty, and there was a reniform structure noted in the right iliac fossa with very small size, and there was no evidence of left kidney. The left kidney was not visualized, so it was likely.
So she has only one kidney, and that's also top.
That has to be confirmed.
So, Dr. Sanjukta, what should have been done, DMSA or DTPA? This child has DTPA report when he came to me. So, what interpretation of the report and what should have been done?
So a DMSA scan I would have preferred to see whether there is any functional component. But some people do a DTPA scan thinking that they will get an eGFR also, GFR value from the DTPA scan. But according to the nuclear medicine people, this GFR is very arbitrary. It's not something we can go with. So preferably I would do a DMSA scan in this child to see if there is any functional component in this kidney.
So, one important message which I want to give you, that only in case when you want to see the exact GFR, and second when you want to see the obstruction, like PUJ obstruction. In all other cases, DMSA scans will be done. DMSA scan will show the area of any scar, also show the position of the kidney, and it can show the differential function also. So DMSA can also show the differential function. So what next, Dr. Viplo?
So the
MCU was done.
Yes. So the child had recurrent UTI, and the MCU showing that there is no reflux, there is no postural valve, the bladder looks absolutely normal. So if you summarize the case, so this is a 1-year-old boy who presented with recurrent UTI. If you go antenatally, there was no ultrasound was done. So this could have picked up in the ultrasound scan because there is a single kidney that is also ectopic position. So we could have taken measures to prevent the progression into CKD. So now the child, because of recurrent UTI, has presented with rising creatinine, the GFR around 45, so that will be around 3A or 3B of CKD. So now what we can do is we can manage conservatively to prevent the further progression into secondary stages, as well as because this is a single kidney and in ectopic position and the child is already on advancing in secondary stages, we could consider having with antibody prophylaxis. Though the ISN guideline doesn't recommend antibody prophylaxis in such cases because there is no significant view or there is no history of bladder wall dysfunction, but because of the previous kidney, many of the nephrologists might consider adding antibody prophylaxis to this child.
So this was the case of a missed opportunity. So now quickly we'll go through some common parents' query. So one query, Dr. Prince, my friend suggested cranberry juice for UTI. Can I give?
Cranberry juice may be of some benefit, but then the problem is that you have to give huge volumes. So which is again very difficult in a small child. So practically this becomes very challenging and very difficult. So not much of use, I would say.
There is a 9-year-old girl with nocturnal emesis, no other urinary symptoms. She has plenty of pus in her urine. Should I treat like UTI?
So just presence of pus does not actually stamp UTI. It has to be with urinary symptoms and culture positivity. Or if we have the, till we are waiting for culture, if we have the cases in our clinic, we can screen for AD nitrite. If it is positive, we can for the time being start antibiotics in presence of urinary symptoms and then wait for the culture.
So, Dr. Sanjukta, same girl shows insignificant colony count growth in urine culture once and polymicrobial growth again. How should I go about?
So, asymptomatic child with this kind of growth, it may be a case that the urine was not properly collected, or a case of asymptomatic bacteriuria. So, we do not need to treat asymptomatic bacteriuria because these are good bacteria preventing growth of pathogenic organisms, and also giving too much of antibiotic can lead to an antibiotic resistance, and this resistant organism may lead to more severe UTI later on.
So, Dr. Biplov, 6-year-old child with fever and chills taking orally well and hydrated, eventually suggestive of acute pyelonephritis. Can I treat with oral antibiotic or give IV?
So all UTI should be started with one antibiotic except in few cases like a very small baby less than 3-month-old, or the child is very sick or having sign of sepsis or anal tenderness, or the child is not able to take orally because of preterm vomiting. So none of the cases, none of the symptoms are present here. So we try to start with one antibiotic and see if the child is responding in 2 to 3 days. If the child doesn't respond, maybe we can consider starting IV antibiotic. But for this situation, we start with oral antibiotics.
So some other query, the child treated with amoxicillin with urine, but culture showing resistance, and we have already discussed no need to change. 6-year-old boy left grade 5 EY and febrile UTI. So responded, started antibiotic, no response. So what to do? So it is very important case. In this case, check culture sensitivity and change appropriate antibiotic. Do USG, look for any turbidity or any collection, and catheterize the child. And last, how long? If cystitis 3 to 7 days, in pyelonephritis 7 to 10 days. So long-term effect is renal scar. So 2 important messages which I got from Pankaj sir during my SRC I have to give. One is never give urine to be collected. So if there is any obstruction, first to relieve this. So if you are like in neurogenic bladder or in PUB, first thing you have to do to catheterize the child. So very obstructive uropathy, if you divert the urine or catheterize the urine, creatinine will ultimately come down. And second, the 2 worst enemy for the kidney is hypertension and proteinuria. So we must check and try to prevent this to save the kidney. So that's all from the panel discussion. Thank you.
Thank you, Dr. Anand. If there are any questions, we welcome. Otherwise, we will. Sir, my question.
Actually, nowadays we are seeing patients come with a routine urine culture report. They have already been treated outside the several antibiotics. Pus cells are present in urine. Leukocyte is positive. Nitrite is also sometimes positive. But it shows pan resistance. An organism grown is Klebsiella or Proteus. I think all of you must have encountered such reports. So what is your approach in treating such cases?
So yes, sir, you are very much right. We are getting such cases, that is antibiotics towards we are going like high-grade antibiotics. That is a pitfall. This kind of children, I would go if I usually start with an antibiotic which we usually start a third generation cephalosporin. If the child is symptomatic and go for a repeat urine culture, which is a catheterized sample with proper collection. And if the child is very sick or worsening, in that case of pan-resistant organism, if the whatever is a higher antibiotic sensitive, showing like fosfomycin, sometimes it is ceftriaxone and ivermectin, we have to start because the child is very sick. But if the child is not that sick, in that case I shall start with the third generation cephalosporin and go with the repeat urine culture, which is sent in a proper way. I shall ask the house also if somebody has something else to add to it. Dr. Jensen.
I agree with you. I would do the same if the child is not sick. You can start with either a cephalosporin third generation or something like ofloxacin and see the response. On the other hand, if the child appears sick, or it's a known patient with a complex urinary tract like neurogenic bladder, very often these children would then require IV administration of meropenem or something. So I think again it's important the lab is reliable and it's not over-reporting and the sample is collected properly.
So UTI is the one condition which usually don't require very higher antibiotics, except as I told in neurogenic or complex Kakut type of things. Any other question? Mike?
So then, what is the position of fosfomycin in the treatment of UTI? So basically it is, as we know, it is single dose and for cystitis. And what is the stand? But as many times we see that it is there is sensitivity to only fosfomycin. So what is the stage? What is the stand here for pyelonephritis, cystitis, and complicated UTI when we are not getting any sensitivity for other antibiotics? Thank you.
Like, I think the answer is same. If the child is very sick and fosfomycin is the only thing that is sensitive, we have to start on fosfomycin. But if the child is not that sick, we can think of starting at a lower antibiotic like a third generation cephalosporin and then go by the lab report, repeat urine culture which has been sent.
Less experience with use of fosfomycin, but then particularly neurogenic bladder, sometimes when everything is resistant and you have only sensitivity to fosfomycin, child doesn't appear very sick, it just appeared urine, you can try fosfomycin orally.
Regarding fosfomycin, I think we have very limited experience using oral fosfomycin, which is actually usually done in adults mostly. And if the child is sick and your catheterized urine sample and culture is showing that it's fosfomycin sensitive, then we have to.
So I think since we are wrapping up, we can wrap up, but just one message is that if you are getting an MD, a multi-drug resistant UTI, most probably, like from my experience, most probably from the community, most probably the symptomatic and the feeling UTI get treated. Otherwise, maybe it is just a contaminant. I usually go for a catheter sample, send it, and then wait also. So that is something that is often done, like multi-drug resistant, go on treating, but make sure that this is properly collected. Because I usually say that we are under-treating UTI, but maybe we are also over-treating UTI.
Thank you, sir. I will request all the panelists and the speaker chairperson to please come for the momentous session. Moving on, next we have no tea break, sorry, but we have to move ahead. And for next lecture, the plenary lecture, the chairperson, I will request Dr. N.C. Prasad sir, renowned nephrologist of the city and former Director-in-Chief of Health Department, Bihar Government. Dr. N.C. Prasad sir, please come on the back, sir. We have Dr. Bhupendra Narayan sir, Head of Department of Pediatrics, Patna Medical Hospital, my guardian and very famous personality all over the PMCS. Please sir, come on the dais. And Dr. Darshan Dandaswamy sir, from Manipal Hospital, Pediatric Nephrologist, Manipal. I welcome you sir on the dais, please come.
Sure.
I will request chairperson to please introduce himself.
Professor Pankaj Hari needs no introduction. He is almost synonymous with the pediatric nephrology in India. I experienced this study with his great presentation and interaction with the other institutes also. In the meantime, tubular disorder is a less discussed condition in the nephrology. So it is a good combination, a grand feature and less discussed condition. So, Dr. Pankaj.
Thank you, sir. I rightly said that the renal tubular disorders are really complex and for a practicing pediatrician, sometimes they can be nightmares. So I would like to keep it simple, try and tell you the important points. First of all, the nephron unit is very complex, and I mean, if the kidney can filter, why can't we have regulators who can just filter the amount of solute and water that is required, rather than having a tubule? But what tubule does is it allows a very fine regulation of all the electrolytes, and maintenance of acid-base balance. So that is why renal tubule is very important. The renal tubular cells, and there are at least 4 segments that you can recognize in the tubule that play a very important or key role in the homeostasis of sodium, electrolytes, acid and base. So one is the proximal convoluted tubule, the other is the thick ascending loop of Henle, the distal convoluted tubule, and the collecting edge. They have their own specific roles. And these cells have a repertoire of various transporters. There are pumps, there are co-transporters, there are anion exchangers, there are channels, and the transport of electrolyte can be either active or passive. Active would require sodium potassium ATPase, and sometimes the transport of electrolyte, particularly calcium and magnesium, would happen intercellular between the cells which are the tight junction, and there are specific disorders of these. So whenever you have an issue with the pump transporters, these is primary tubulopathy or primary renal tubular disorder, which is invariably inherited. And there are multiple genes now which have been discovered, and the list keeps growing. The second form is an acquired or secondary tubular disorder, which can happen in an autoimmune disease or whenever there is a chronic tubulointerstitial damage to the kidneys. And this is apparent damage to the tubular cell. So, with the damage to the tubular cell, even the pumps, the transporter, they are also lost. And therefore, you can have a mix of, problem in the reabsorption or losses of sodium, potassium, chloride, etc. On the other hand, if it's a particular transporter that is affected because of a genetic cause, then you have very specific abnormality. So when does a pediatrician would suspect a tubulopathy? The commonest symptom is polyuria and polydipsia, and this is very often associated with poor weight and height gain. The question of salt craving, whether children have more taste for sweet, and they do not have a well-developed taste for salty things. So if there is a clear history of salt craving, then that means that this child is having a salt-losing nephropathy. But however, this is a very tricky question. If you are asking directly, sometimes the answer may turn out to be yes, may not be true entirely. Then the child can even present with the electrolyte abnormality presenting as a neck flop, which is hypokalemia, or an ILS, or hypocalcemia, which can present as a tetany, or you can have muscle cramps when there is hypomagnesemia. There can be deformity. This can be a presenting feature where the child may present to you as rickets. You will first treat him as a vitamin D deficiency ricket. The child doesn't respond. You start suspecting a renal tubular defect. The child can also come to you with renal stones, and there again the workup can be done to find out whether there is any tubular defect, or sometimes there can be dense deposition of calcium within the renal parenchyma, which is called as nephrocalcinosis, which can be a presenting feature in some of the patients, and very often you will find an underlying cause. And rarely a tubular disorder can present as an unexplained hypertension. And these are very rare disorders. Of all the hypertension, these will just constitute about 2 to 4%. But sometimes, and this is the job of maybe the pediatric nephrologist to figure out these disorders. In addition to these symptoms, which are the usually identifying symptoms, once you figure out that there is a tubular disorder, it may be wise to look at the ears and eyes, because very often a lot of these renal tubular disorders will have the defects in hearing in the form of sensory hearing loss, eye abnormalities such as keratopathy, coloboma, corneal erosions, cataract, glaucoma, and also look at the teeth. While with rickets you can have development defect of the teeth, but sometimes amelogenesis imperfecta, enamel is discolored, and you can find that if that kind of a thing is there and there is polyuria, polydipsia, you may be dealing with a specific genetic defect. So how does one approach to the diagnosis of renal tubular disorder? There are two kinds of approaches. One is a geographic approach, or what is called a segmental approach, where you go by the abnormalities, whether they are localizing to one segment of the renal tubule. For example, if you have, proteinuria low molecular weight, you have bicarbonate loss, you have phosphaturia, then you know that combined such a thing is happening, it's likely to be the proximal convoluted tubule. Similarly, you can localize your abnormality to the distal convoluted tubule, or if there is a loss of sodium and chloride, which is something similar to what happens when you give diuretic like Lasix to a patient, then that means you're dealing with the defect in the NKCC2 channel, which is at the thick ascending loop of Henle. So we have different segments of the tubule which have a specific work. The proximal tubule is chiefly with the reabsorption of water and solute. The thick ascending loop of Henle, as I said, it is the NKCC2. Distal convoluted tubule, where the thyroid diuretic would act, again is important in salt and water loss, and the collecting ducts, which are the EMAC channel and the aquaporin receptor as well as aquaporin channel, they are primarily responsible for urinary concentration, and therefore the defect here would result in something called as diabetes insipidus. So in the segmental approach, this is again the same thing, that if you have phosphate glucosamine acid coming in the urine, or renal glycosuria is there, then you know that there is a proximal tubular defect. Very often the proximal tubular defect is a combined defect, what is called as Fanconi syndrome. Isolated proximal RTA is very uncommon. Similarly, you can have a defect of the thick ascending loop of Henle, with the condition would be severe sodium and chloride loss, which is the Bartter syndrome. There can be, in addition, magnesium loss, which is happening at the distal convoluted tubule, which is the Gittelman syndrome, and also the distal renal tubule. You can have abnormality in the collecting duct, which can be rare disorders. These are very rare disorders like pseudo-hypoaldosteronism. So these again can be only sorted out at the level of a pediatric nephrologist. So the common symptom is polyuria, and the first thing that the practitioner should do, that if you have a child with polyuria, please confirm whether there is truly polyuria. And sometimes they may just complain with the parents that the child is passing a lot of urine. But a true polyuria would mean that the child, an older child, even gets up at night to drink water and passes urine. The amount of urine that qualifies for true polyuria is 2 liters per meter square. And generally we would not use milligram per kg per hour or something. So 2 liters per meter square on multiple occasions, if it is high, then definitely there is polyuria. Then the next thing that you do is you look at the electrolyte abnormality. If there is no abnormality in the potassium, gases are okay. If there is only sodium abnormality, then you can look at the osmolarity. When you're looking at the osmolarity, that will be the second test that you, with the polyuria, look at the osmolarity. If it is available in your practice, then you should look at the first morning urine osmolarity, because generally the time when the child hasn't had water, so it is kind of a deprived state. So it will tell you about the concentrating ability of the kidneys. And generally, if that urine osmolarity is more than 200 to 400, then that means there is the free water loss is not happening. The polyuria has both water and solute loss. On the other hand, if the urine is very dilute, if the osmolarity of let's say 100 or so, then perhaps you are dealing with diabetes insipidus. There is only free water loss that is happening. If that is so, then you can subject the child, and the rest of the electrolytes are all normal, then you can subject the child to water deprivation test and look at the concentrating ability to dehydration. And then this test is followed by giving vasopressin challenge. If there is a response to vasopressin, then you know that this is central diabetes insipidus. If there is no response to vasopressin, then this could be nephrogenic diabetes. Now again, sometimes there are partial forms of nephrogenic diabetes and also central diabetes, which are really complex to differentiate. And again, as I said, then they could be done only in a higher center with a better understanding of these conditions. On the other hand, if you have salt based and you have figured out that your sodium excretion, fractional excretion is high, osmolarity is also almost like 400, then at that point of time you should try and look at the blood gases, which will be telling you whether there is presence of acidosis or alkalosis, and what is happening to the potassium, whether it is hyperkalemia or hypokalemia, and depending on that you will classify your disorder. So let us look at if you have a biochemical abnormality and the child walks in with hyperkalemia or a normal potassium. So generally first thing you will look at whether the child is having increased intravascular volume or decreased intravascular volume. Now most of the time the renal tubular disorders will actually have salt and water loss. So they are in depleted state. So in that, rarely you will find that the volume is increased, which is very rare that you will find a condition like called Little syndrome, where there is increased activity of the ENaC channel, which is the epithelial sodium channel, through which a lot of sodium and water will enter into the body, and that will cause hypertension. So generally the intravascular volume is increased. This is a rare condition, presents as hypertension. So if you have a normal blood pressure and you have hypokalemia, then you look at the blood gases, there is acidosis. Perhaps you are dealing with one of the forms of renal tubular acidosis. It could either be proximal renal tubular acidosis or distal renal tubular acidosis. If there is alkalosis, you are perhaps dealing with either Bartter or Gentleman syndrome, or there is another condition which is called as familial hypomagnesemia, hypercalciuria and nephrocalcinosis, which can also present as alkalosis and hypokalemia. Hyperkalemia and acidosis, these are again uncommon conditions, and this would be something what is called as pseudo-hypoaldosteronism type 1 or 2, or what is called as Gordon syndrome. Again, they are very complex abnormalities, and again differentiation would mean that you sometimes open the book and find out which abnormalities each test to be done. Normal potassium, only water loss, you perhaps dealing with nephrogenic diabetes. So these are the investigations that should be done in renal functions. You should first look at, once you are investigating for a tubular disorder, your renal function should be normal. In fact, most of the time, if there is an abnormal kidney function where the creatinine is high, and then you're finding electrolyte abnormalities, you're perhaps dealing with a secondary tubular dysfunction, and the patient is actually a CKD. So you do not label this as primary tubulopathy or an inherited disorder of pumps and channels. So you look at the sodium, chloride, magnesium, the bicarbonate, pH, and gap, calcium, phosphate, parathormone levels, uric acid in some of the conditions, hyperuricemia is seen, and in the urine you would look at the total volume, 24 hours, osmolarity. The urine pH is important when you're dealing with renal tubular acidosis. 24-hour urine collection for calcium, phosphate, total protein, and in specific situation you may look at the tubular protein, which is the beta-2 microglobulin. Generalized passage of amino acidogram or amino acid, which is amino acid urea, which can happen in some proximal tubular defects, and magnesium levels, important in magnesium losing nephropathies. So this is a list of tests that you could be doing. Phosphate is typically assessed as tubular maximal phosphate. Again, for beta-2 microglobulin, do 24-hour urine collection. Then I also tell you how to do a fractional excretion of bicarbonate. And these are specific tests for specific condition. For tubular acidosis, you would do a bicarbonate loading test, a fluid robotic and furosemide test. For DI, you would do a water deprivation test, and so on. For magnesium losing nephropathy, you will look at the fractional excretion of magnesium. So what is the fractional excretion of a substance? This is again determined by the UV by P method, which is you look at the urinary values and the plasma value of that electrolyte, and you also use the ratio of plasma creatinine and urine creatinine. So this way you can find out FEK, which is fractional excretion of potassium, fractional excretion of phosphate, and also fractional excretion of magnesium. The FePO4 is not just given as a fractional excretion, but you actually look at the tubular reabsorption. So you subtract it from 100, so that will be tubular reabsorption. But again, since the phosphate excretion is determined by the renal function as well as the serum values, therefore you will have to use a chart which is called the Digowitz nomogram, where you plot the value of fractional excretion plasma phosphate, and then you determine whether what is the value, whether it is higher than 2.3, which is mean, or lower than that, which would mean there is phosphate urea. I'll be discussing bicarbonate loading test and the urinary acidification furosemide fluorocortisone test with you. Understand that the samples, generally we would prefer 24-hour urine samples. So sometimes if it's a very young child, infant, then you may need to in fact admit the patient, catheterize, do 24-hour collection there. And again, it's important to these tests multiple times because urine estimation of electrolytes is sometimes very variable, and therefore you would have to prove them on multiple occasions to call it that this is your phenotype. In renal tubular acidosis, you will suspect when there is normal anion gap acidosis with hyperchloremia. A urine pH of more than 5.5 is suggestive but not diagnostic of RTA. So you need to do other tests to find out what kind of tubular acidosis you're dealing with, whether it's proximal or distal. When you're looking at the urine pH, always use a pH meter rather than using the strip. Strip is unreliable. pH, again, your pH meter should be calibrated. You should be looking for urine pH in a fresh sample, because in a standing sample, the CO2 will be lost, and so the urine will turn to be alkaline, or the bacteria there will also break down the urea which is present. Particularly, this is true of Proteus, where therefore you will have an alkaline urine, and may falsely give you an impression that this is alkaline urine with acidosis, so this is RTA. In the bicarbonate loading test, why do you need bicarbonate loading? So it's important to know that if you have bicarbonate loss that happens in proximal tubular acidosis, if you have very little bicarbonate to be filtered, then your bicarbonate reabsorption would appear to be normal. So therefore, you have to do these excretions in a loaded state. You have to normalize the bicarbonate level, which means you have to raise these plasma bicarbonate through either oral or IV bicarbonate, sodium bicarbonate, slowly to the bicarbonate value should be, blood bicarbonate should be more than 20, and the urine pH should be at least more than 7.5. And then you do the fractional excretion of bicarbonate by using a blood gas machine. If the fractional excretion turns out to be less than 5%, which is normal, in proximal RTA there is massive loss of bicarbonate, so the bicarbonate excretion is generally more than 15%. In the distal RTA, it is actually the acidification defect, so the anions are not being excreted, and it's not the bicarbonate. So there you have to find out whether the distal acidification is intact. The fractional excretion of bicarbonate will be in the normal range. So what you do then is you look at the urine to blood CO2 levels. So CO2 in the urine is produced in the presence of H ions. So H ions will combine with HCO3 to form H2CO3, and then this CO2 is lost, and that is the CO2 that we're measuring. So if there is no H ion in the urine, then CO2 will not be formed, and therefore urine minus blood PCO2 will be either very low, which is suggestive of distal RTA less than 10, or if it is more than 20, then this is normal. So another way of testing the distal acidification is to use the furosemide on fluorocortisone. So what it does is, if you can see that this is the principal cell and the alpha intercalate cell, there is one important channel which is MENA in red, and there is another HTPase which is important for H secretion. So under the influence of aldosterone, these two, the channel and the other is a pump, they will be acting, and therefore when you're giving fruits, and you also need a lot of sodium in the lumen to acidification to happen. So in order to facilitate this, you give furosemide. So there is a lot of distal delivery of sodium in the tubule, and this sodium is then taken in by the action of aldosterone through the ENaC channels, and then the H ions are secreted. So this would then tell you about whether the urinary acidification or H secretion is intact. You use a furosemide of 1 mg per kg, and you add to it fluorocortisone, which helps, which is actually functioning for the aldosterone action. You also do a control sample of either a sibling or a parent to see whether the acidification you test is running correctly or not. or failure to show lowering of urine pH to below 5.3 within 6 hours means there is impaired distal acidification, which is important also in incomplete distal RTA, where patients' bicarbonate may be normal, and these patients, generally adults, would present as recurrent stones. So this is a summary of approach to metabolic acidosis. You will see that you find in urine, generally we don't do urine anion gap. If you have an anion gap, normal anion gap, hyperchloremic acidosis, you consider renal tubular acidosis. Then you look at these bicarbonate loading tests, urine minus blood CO2, and classify them into either proximal RTA or the classic or type 1 distal RTA, or sometimes it is the hyperkalemic kind of RTA, which is the voltage defect. This will be, instead of hypokalemia, there may be hyperkalemia in a distal RTA. And then there could be what is called as type 4 RTA, which actually is the aldosterone defect, and typically these patients will have, again, hyperkalemia. You can have a mixed RTA, which is, again, because of the deficiency of carbonic anhydrase enzyme, which is there in both proximal and distal RTA. So you have both dysfunction of proximal and distal RTA, you are not able to acidify the urine. Tubular syndromes, and there are various genes that are listed here that have been known, and you just have to suspect it. Your phenotype is a Fanconi. You tell the genetic testing lab that this is the condition you are suspecting, and they will test for all these genes. Isolated primary RTA is uncommon, wherein the other abnormalities will not be there. There will be only bicarbonate loss. There could be associated eye defects, enamel defects, and also sometimes intellectual impairment and basic ganglia calcification. And this picture on the right side is of a slit lamp examination where it shows corneal deposits of cystine crystals. Cystinosis is a very common cause of Fanconi syndrome, and it leads to even progression to CKD. So, coming to the etiology of distal RTA, so they can have this defect, which is amylogenesis imperfecta. You can have the RBC ovalocytosis. So these are the 5 genes which are known for distal RTA. One of them can be associated with hemolytic anemia. So if you have a child presenting as a renal tubular disorder requiring blood transfusion, think about this condition. Or if you have a hearing loss, very often the distal RTA may be associated with hearing loss. So hearing evaluation should always be done. And be aware that sometimes chronic conditions can result in secondary RTA, which can be drug-and toxin or systemic disorders, or obstructive uropathy can even result in similar kind of picture as distal tubular acidosis. We looked at the outcome of renal tubular disorder in the hospital over more than 135 children, and of course, of which most of them had Fanconi. 69 were distal RTA, and the commonest variant was SLC4A1, and also ATP6V1V1. Cystinosis is the most common cause of Fanconi syndrome in our patients, and almost 3 to 5 and 3% patients had shown progression to CKD stage 3 to 5. So there are some tubular disorders which will progress to CKD, you must remember, particularly cystinosis. Dents can progress to CKD. The familial hypomagnesemia, hypercalciuria, nephrocalcinosis progresses to CKD, and rarely a distal RTA can also progress if there is significant nephrocalcinosis. How does one approach a patient who is presenting as metabolic alkalosis? The first thing is you look at the urine chloride. If there is a urine chloride loss, that means the kidney is responsible for the chloride loss. If the blood pressure is normal, then you are taking either Bartter or Gentleman or syndrome. If the blood pressure is high, then you should look at aldosterone, and then there are other rare conditions that can be there. Talking about Bartter syndrome, there are 5 types of Bartter syndrome. the various transporters that are defective in each of them. They can present either in the neonatal period, with very severe form, particularly 1, 2, and 4 can present in the neonatal period with polyhydramnios and prematurity and very severe salt wasting. And sometimes it's very difficult to, in fact, keep these children well hydrated, and you lose them because of severe dehydration very often. They may be associated with hearing loss, particularly the Bartter type 4, which is because of the deficiency of the Barton subunit. And there is also a transient form of Bartter syndrome which can happen in the unit, which reverses on its own, the type 5 Bartter. Then the tubular disorder could be resulting in magnesium loss. And here if you find that a serum magnesium, so again when you suspect tubular disorder, do a serum magnesium. The serum magnesium is low, less than 1.6, then you will have to look at the fractional excretion of magnesium, which is again calculated by the same method as you calculate fractional excretion of any other solute, except that only 70% of magnesium is filterable. Therefore, you have to use a factor of 0.7. If there is acute magnesium more than 4%, then there is renal magnesium loss. Think of Bartter syndrome, Gentleman syndrome, which are associated with the magnesium loss. If it is non-renal magnesium loss, then this could be diarrhea, etc. Then further in your hypomagnesemia, you see whether there is hypercalciuria or normal calciuria. Then there are a list of disorders that are hypercalciuria or hypomagnesemia, like I said, familial hypomagnesemia, hypercalciuria, and hypocalcinosis. These are the Claudin genes, 16 and 19, type Bartter syndrome type 5, type 3. They will all have hypercalciuria, hypomagnesemia. Then there are several hypomagnesemia which have normal calcium excretion, and accordingly you can classify. So the common mistakes in dealing with the patient party is trying to evaluate a renal tubular disorder during a diarrhea or sepsis episode. There can be acidosis, urine pH can be alkaline, but then the patient should be in a normal state of health before you even begin the examination. He should not be on any drugs, he should not be on IV fluid. Diagnosing RT in the presence of derenal function, I said this is damage to the renal tubules, and therefore the abnormalities of sodium chloride, etc. can be there, but this is not primary tubular disorder. Making a diagnosis of RT in the presence of acidosis and high pH alone, you must do a phenotype with the bicarbonate loading test, etc. And diagnose it or trying to do a bicarbonate excretion in a non-bicarbonate loaded state will give you a wrong analysis. And with hypophosphatemia, just don't label them as hypophosphatemic rickets. There could be other complex disorder like hypercalciuria, magnesium loss. Now, is there a need to do genetic testing in these patients? We have phenotyped it. Most of the time the treatment is just replacing the solute. But genetic testing allows precise diagnosis. There can be a lot of phenotype variation. And often sometimes there are, the phenotype is the same, but the genes are very different, which are called as phenocopies. It also allows for prenatal diagnosis of a very severely affected Bartter syndrome. You know the gene, you can do prenatal testing for the next pregnancy, and you can avert another Bartter being born. It can also assist you in prognosis determination, and sometimes can help you in reverse phenotyping. Reverse phenotyping is, you know a gene now, you go look back into the manifestations of that particular disease. Incorrect genetic diagnosis. Treatment is generally replacement of solute in water loss. So for RTA, you would give potassium citrate. Cystinosis has a specific treatment called cysteamine. It's very expensive. It's still not affordable by most of the patients. For hypophosphatemic rickets, you will replace with phosphate, sodium acid phosphate. For Bartter, again, potassium replacement, magnesium replacement. You can use spironolactone, indomethacin, because they are hyperprostaglandin secretion is happening. So indomethacin helps in reducing the potassium loss and even the polyuria. For gentlemen, again, potassium magnesium supplementation. So to summarize, tubulopathies can have variable presentation. They require high index of suspicion and right test. Diagnostic algorithm can vary. There is a critical role for serum and urine biochemistry, and repeatedly you must do the testing to phenotype these patients. Genetic diagnosis is increasingly feasible and accessible. The gene list is rapidly expanding. It allows for correct diagnosis, genetic counseling, and even prenatal testing. And among all these things that you can figure out, the treatment of tubular disorders is most simple in the form of replacement, but the diagnosis is far more complex. Thank you very much for this.
Thank you, Dr. Hari, for nice deliberation on such a complex subject. And the last, we have to diagnose tubular disorder. We have wide vision, not tubular vision. Thank you.
Thank you, sir. I will request the speaker and all the chairpersons to please come for the memento distribution. I will request Pankaj Hansal to please come for the memento distribution. So, this ends with such a nice talk by Dr. Pankaj Hari sir, his writing talk. We are moving to next part of the session, that nephrotic syndrome symposium, and on this Mahakumbha of pediatrician, pediatric nephrologist, adult nephrologist. I think this is going to be the most important and most interesting session, nephrotic syndrome symposium. And for chairing the first session, I will request Dr. Preet Pal Singh, Associate Professor Nephrology, IGMS, sir. Dr. Rishi Kishore from the Ford Hospital. Dr. Rajeshwar Rao, sir, and Dr. Geeta Bipin Chandra, and nephrologist, famous nephrologist. I request you all to please come on the dais, and I request Dr. Shubhankar Sarkar, if speaker, please.
Topic for the discussion is different aspects of the nephrotic syndrome. For this, we have the speaker Dr. Shubhankar Sarkar, and he is the assistant professor in the All India Institute of Medical Science, Kalyani, and he has a different publication and he is the area of interest is the glomerular and tubal disease and acute on chronic kidney disease. So over to you, Dr. Shubhankar.
Thank you, sir, for kind introduction. I also thanks the organizing team for organizing this APNEICON in Patna. So whole team is very nicely organizing team. So I also thanks Dr. Gopal Prasad sir for organizing such a beautiful program. So another next important topic after like API in pediatric nephrology is the nephrotic syndrome. So nephrotic syndrome, I will start with the case. Is a Mr. X is a 4-year child with swelling of the whole body. Developed after 1 week of upper respiratory tract infection. You can see the swelling, the eyes is fully puffy and body is also swollen. And on evaluation is found that child is having inner circle is a whole body swelling with blood pressure is normal like 110/60. Urine dipsticks done from the labs that shows that a 4+ urine protein with serum albumin of 1.6 gram per deciliter. Cholesterol is 440, so high milligram per deciliter. So what is the diagnosis? I think we can guess that it's a clearly case of nephrotic syndrome. So nephrotic syndrome is a combination of proteinuria and hypoalbuminemia, and sometimes the cholesterol is high, many times actually, and the swelling. This all together is combined is a nephrotic syndrome. So the nephrotic syndrome guidelines evolved over a period of time. The first consensus guidelines that published in Indian Pediatrics by Professor Arvind Bagga and the whole team of AIIMS New Delhi, and subsequently it's updated in 2021 in a better way with more evidence base that the diagnosis is based on proteinuria, hypoalbuminemia and edema. Then the international group emerged to publish the guideline. 2020, the KDIGO guideline published this as a part of glomerular disease, and then subsequently they